We described the pharmacokinetic and pharmacodynamic properties of anti-infective agents used for the treatment of STIs and explained the pathophysiology and clinical presentation of some of these STIs. Now let's interpret diagnostic laboratory findings to confirm the presence of genital herpes, gonorrhea, chlamydia, or syphilis in a patient. Let's take a look at diagnosis of genital herpes simplex virus infection. Now, if the genital lesions are present, clinical diagnosis should be confirmed by a type-specific virologic testing from the lesion, and that's typically with a nucleic acid amplification test, and that has a pretty good sensitivity of that approaches almost 100%, so 91 to 100%. Whereas if you were to culture this, sensitivity of viral culture is low. And then there is a type-specific serologic test. So serology is actually from the blood, whereas that nucleic amplification test was done on the specimen directly from the lesion, which means there is no lesion. You can't really do this test because you need to have a specimen. Whereas serology can be done at any time, whether there is lesion or not. So essentially, you want to see if someone has, latent HSV. And the serology test that's type specific, it can distinguish between HSV1 and HSV2. It essentially detects different glycoproteins from each of these. And it has a good sensitivity, 80 to 98%, but it has a poor specificity. So when there is a positive test, you have to make sure that it's not a false positive. So it needs to be confirmed with a second method. Now, these say type specific because there are some tests out there that are type common antibody tests. They just tell you if somebody has HSV infection. It doesn't distinguish between HSV1 and 2. So the CDC guidelines from 2021 do recommend to use type specific so you can distinguish between HSV1 and 2. And that's implications for treatment because we know that if it's HSV1, it's less likely to have recurrences, whereas HSV2 is more likely to have recurrences. So that essentially determines our treatment strategy, which we'll cover shortly. Now, when it comes to screening, these are the US PSTF recommendation. So they recommend against routine screening by blood test, so essentially the serology test for genital herpes infection in asymptomatic people, including pregnant individuals. So it's not recommended. It's only when people have symptoms that then you essentially do the NAT and diagnose them with genital herpes. Now, when people do have genital herpes, those ulcers actually increase the risk of HIV transmission. So for that reason, all persons with genital herpes should be tested for HIV. Now, diagnoses of chlamydia and gonorrhea are pretty similar. So essentially, you use nucleic acid amplification test from the specimen. And the specimen is essentially the site of infection. So for women, if it is a urogenital infection, so vaginal or cervical swabs, or you can use a first void urine test to detect either chlamydia or gonorrhea. And typically these are tested at the same time. So because the manifestations are pretty similar, when you suspect one, you test for both of these. So that makes it more straightforward. For men, urethral infection can be diagnosed again using first void urine or a urethral swab. And I will tell you that most routinely people just get the urine sample for these. If you suspect the route of transmission was rectal or oropharyngeal, those sites can also be swabbed because a urine sample might test negative where somebody may have oropharyngeal infection. So all three sites may be needed to be tested in certain individuals with risk factors. And something that's specific for chlamydia and gonorrhea is that patient collected specimens are equivalent in sensitivity and specificity to those collected by a clinician using that. So it doesn't matter if the patient swabbing, for example, doing a rectal swab on their own, or the physician doing it. So technique is not really as important, or at least the studies have not shown much difference. Now, while we're doing diagnosis of chlamydia and gonorrhea, because of the common risk factors, these people should also be tested for HIV and syphilis. Now, when it comes to diagnosis of syphilis, it really depends on just it relies on serology. So because this is not something that will have specific specimen, because for the most part there will not be a specific size. So primary syphilis, you can have some lesions, but outside of that, you're not gonna have specific specimen. So diagnostic relies on serology, so you need blood samples, and so in the case of neurosyphilis, you may also need a lumbar puncture to get CSF sample. But outside of neurosyphilis, essentially you're relying on serology, and we divide these into two groups. So we call some of them non-treponemal tests, and the other group is treponemal tests. And the difference is that non-treponemal tests measure antibodies in response to lipoidal materials, whereas the treponemal tests are antibodies directed specifically against the organism itself. And so there are pros and cons of each group, but the commonly available products essentially in the US is the RPR test for non-treponemal test, and that's rapid plasma reagent. And that essentially a blood test, and there are other options that I personally have not seen used, but for CSF specifically to see if someone has neurosyphilis, there is the VDRL test. So you need a CSF sample to do this test, and that's essentially stands for venereal disease research laboratory test. And then for the treponemal tests, you have different options. That the one that I have seen commonly used in the US is the TPPA, so the T pallidum passive particle agglutination. And how do we use this, right? So essentially, one thing to keep in mind is what happens with this serology. So here on the x-axis we're looking at time, and the y-axis we're looking at patients who test positive, what percentage test positive. I can see that essentially after 4 weeks of treatment, so sometime between 4 weeks and 6 months is when non-treponemal tests becomes detectable, so RPR for example, as well as treponemal antibodies, so TPPA. Now with TPPA, because it's directed at the organism, these antibodies will last forever, right? So even if someone had an infection in the past and it's been successfully treated, these are gonna test positive over time, regardless of whether they have an active infection or not. Whereas non-treponemal antibodies, once the organism is cleared, the levels actually go down. So if it's treated and seroreverted, meaning that antibodies will go away, so over time it goes down. And even if you don't treat it over time, these levels go a little lower, but still be detectable. So that's something to keep in mind to see what happens over the course of infection, and specifically what happens with treatment versus no treatment. And there are two different algorithms for diagnosis. The traditional way is that you essentially start with one of the non-treponemal tests. So in the plasma, it would be RPR. And if it's negative, you do not treat. And if it's positive, you do a confirmatory test. So then you use a second test to confirm it. So if you use the non-treponemal test, then you confirm with the treponemal test. and then if it's positive, you confirm that it is a true positive and you treat. But then if it's negative, then you assume that this was a false positive, so you do not need to treat. Okay. Now, this is something that traditionally was used. The problem is these tests are not perfect. So when your RPR is negative, there's a chance that this actually might be a false negative and you may miss some people. So then there was the reverse algorithm where you do the opposite. So instead of starting with non-troponemal test, you start with your troponemal test, and if it's negative, you do not treat. Whereas if it's positive, then you get confirmation with your non-troponemal test and then you treat. So both of these algorithms are out there, and they have strengths and limitations. So and that's because these tests are not perfect.